Welcome to the NWAETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Well, I'd like to give a big thank you to Dr. Susan Graham for coming to do a talk today. I asked Dr. Graham to do a two-part session on ART initiation in resource-limited settings. Dr. Graham is on the faculty here in the Departments of Medicine, Global Health, and Epi, and I will turn it over to her.
Thank you very much, Brian. So, Brian really wanted me to sort of encapsulate a little bit about patients coming from resource-limited settings and sort of, what a provider here might need to know about treatment recommendations and how those differ and how really care differs in such settings from here in the U.S. I started working in Kenya as an infectious diseases fellow here at the University of Washington, and went to Kenya in about 2003. Just as the ART scale-up was beginning in 2004, 2005, with the beginning of PEPFAR, which is the President's Emergency Fund for AIDS Relief. And I started 2 ART programs there at University of Washington research sites, so sites where we had ongoing cohort studies. One had been in Mombasa since 1993, primarily serving high-risk women, including female sex workers. And then we started another site while I was in Kenya that serves both men and women who are high risk, including male and female sex workers and men who have sex with men. And I really got involved in sort of scaling up the ART care, putting monitoring processes in place at those clinics using WHO guidelines. So I can share with you sort of what's happened over time and what you might expect. So the outline of what I'll go over today, we'll just talk briefly about the scale-up, where we are with that and its effects on mortality. We'll talk about care. Today we're going to focus on treatment eligibility, sort of the care cascade, what kinds of diagnostic testing are recommended by WHO and available in such settings. I think it's important to touch on TB-HIV co-infection as a major cause of mortality in HIV-infected persons in these settings. And then I'll talk about initial treatment regimens, how those differ from what we have here in the States. And then just a mention of prognosis for immigrants who come to the U.S. and what the available evidence is. Next week we'll touch on drug resistance and monitoring and treatment failure. We hope that context will help you understand maybe where some of your patients are coming with their treatment histories. So the ART scale-up has really been very successful. There were meant to be 3 million by 2003, and then there were meant to be, there were a lot of goals, but in general, there has been a steady increase since the time that really funding was released, which was around 2004, 2005. And as you can see from this graph from the last UNAIDS report, that increase has been extremely dramatic in the area most heavily hit, which is sub-Saharan Africa, with very sharp increases over time. It is still treatment is not reaching HIV-infected individuals in a number of regions, and I think it's important to know that in Middle East and North Africa that their coverage of HIV-infected persons is very low. There's a huge stigma in those areas, and also in Eastern Europe and Central Asia that sometimes those folks are underdiagnosed and undertreated compared to areas of the world where there's a lot more programming and support for HIV care. So all of this treatment scale-up has resulted in a global decrease in AIDS death with the numbers declining. Of course, that means that the numbers of people living with HIV is increasing. And so there are a very large number of people living with HIV, many of them on ART in resource-limited settings, and just over half, almost 2/3 of HIV-infected persons in Africa are on treatment. This is a complicated table that basically shows you the moving target that has been treatment eligibility guidelines. And really the top line says is the most important in that just like US guidelines have moved towards treating more and more people at higher CD4 counts in resource-limited settings, the WHO guidelines have moved from 200 to 350 and are now at 500. Irrespective of WHO clinical stage. So more and more people are eligible for ART and getting treatment to a certain extent. You know, so there are special groups such as pregnant women. The guidelines have also changed, and now there's a set of populations that are treated in WHO guidelines irrespective of the CD4 count or clinical stages, and these include HIV-positive pregnant women, individuals with tuberculosis co-infection, and individuals with hepatitis B co-infection, specifically those with liver disease. As well, after the results of HPTN 075 showing that ART can lead to very significant reductions in transmission, the WHO guidelines do recommend that HIV-positive individuals in serodiscordant relationships be treated in order to protect the partner. That's very new and really only in the 2013 guidelines. Actually, I believe they announced it in 2012. But knowledge of practitioners and particularly of patients that is an indication for treatment is lagging a bit behind the guidelines. Now, just as in the US, one of the major problems with getting people on treatment, even if they're eligible, is when they present for care. And just as in the US, and probably even more so, in a lot of these settings, people are presenting with very advanced HIV. And although that the median CD4 count at ART initiation is increasing in many settings now due to the new guidelines, there's still a substantial number of people presenting late, which of course is associated with increased mortality and poor retention and care. And a lot of this is due to stigma. Even though treatment is widely available and people have good results on treatment, HIV stigma is a very important problem in many, many settings. There's some evidence that it may be worse for men. Women have better access through prenatal care, but men tend to, in a number of studies across sub-Saharan Africa, men tend to present later with more advanced disease than women, and often are not retained in care as well as women are. And then there are certainly high-risk groups, most at-risk populations, as WHO calls them, that have really important barriers to care. This includes men who have sex with men. As many of you may know, male-male sex is illegal in a very large number of countries around the world. There's a very large stigma associated with homosexuality. So those men have barriers to care and have really poor access to tailored services and counseling. Persons who use drugs, similarly, in a number of countries, there's a huge stigma with them seeking care. And sex workers in general also face barriers. And in resource-limited settings, there probably are more people who are involved in transactional sex just because of poverty in many areas. So that's an important population. In terms of the care cascade, the focus in the US on the care cascade is slowly trickling to other settings. WHO's 2013 guidelines now focus on points of entry and points of exit from care, but that's relatively new, and there are very few publications on care cascade within countries or across regions. It's thought by WHO that only about half of the people who are living with HIV actually know of their status. That's true in Kenya, where I work. There are quite a large number of people who are not testing. That's improving slowly. The only systematic review I could find of HIV-positive patients in a care cascade format looked at sub-Saharan Africa and found that about on median of 59% of persons diagnosed with HIV actually received clinical staging or CD4 counts, enabling them to determine eligibility for ART. So a large number of people are not even receiving a CD4 count or staging. Less than half of those initially ineligible for treatment are retained until eligibility, so that's a huge point where patients are lost because they're not coming back for monitoring. About 2/3 of those who are found to be eligible are initiated on treatment, and some of this has been behind the push for starting people then earlier, and even a push for treatment as prevention, which would not require the CD4 count in order to determine eligibility. Basically, the faster you can stage people and get them on treatment, the better they're likely to do. In terms of diagnostic testing and or sort of testing, I guess laboratory testing would have been a better title. One of the big problems in these areas is extremely limited access to laboratory services. I think we've all heard about this in Liberia and the places touched by Ebola, that patients often are dying because of lack of monitoring for just routine electrolytes often. CD4 counts are fairly available in many settings, especially in urban areas. CD4 counts are largely available, and they're recommended for monitoring by WHO. These are, my table includes those tests that are recommended by the WHO, and note that viral load is not on here. Even in the 2013 guidelines, viral load is something that is only available in a limited number of settings, and so it's recommended if possible, but it is not a routine test for most people. In terms of monitoring for toxicities, hemoglobin is recommended to be checked for AZT use. They say desirable for ALT and creatinine clearance. There are a very large number of people who are starting without baseline labs. If available in most of the larger cities especially, people might have a baseline ALT or creatinine or hemoglobin before starting. Pregnancy testing is more widely available, and they don't really emphasize it that much anymore. Actually, it used to be that it was emphasized because everyone was afraid of putting people on efavirenz, and that has changed over time. So now it's just desirable to know if the woman needs to start treatment regardless of her CD4 count, basically. In terms of other screening, the one thing you'll see that's consistent across the guidelines is screen for TB, and we'll go over the reasons for that. Screening for other co-infections and comorbidities has really not been emphasized until recently, and I think as we get a push for earlier treatment and we're more aware of non-AIDS defining types of problems that patients have, the list of things that are desirable to screen for has increased. Blood pressure measurement is something that is recommended, that probably can be done in almost any setting. But I think it's important to be aware that the vast majority of testing for co-infection is really not available. The laboratory testing is not out there, so most people are going to be starting treatment without hepatitis B and C screening, basically be unaware of their hepatitis status. There are some cryptococcal antigen tests that are urine-based and sort of cheaper, again, not as widely available as one would hope. And there's a new focus on screening for diabetes and cardiovascular disease, which really has yet to be implemented outside of research settings. So there's a sort of a creep towards a more comprehensive care evaluation of patients over time, but still reliance on CD4 count for most of the monitoring, which is tricky, and we'll discuss more next week. In terms of TB-HIV co-infection, this is from the WHO Global TB report from this year, the figure is, and basically you can see how TB and HIV have really just sort of amplified each other. Well, HIV amplifies TB to a huge extent, and you can see the countries in South Africa that have the highest HIV prevalence in new TB cases. These are the places that have the highest TB incidence in the world right now. So Swaziland, Lesotho, and South Africa are the top three. I think Namibia may be fourth, in terms of TB incidence. So the problem of controlling TB and HIV infection is very important. That's why this TB screening is so important and emphasized. TB is extremely hard to diagnose in patients who don't have classic presentations with sputum smears that are positive. And so really the push towards earlier treatment is going to be very important, and there is a renewed push towards using isoniazid as a preventive therapy, which I won't go into that much due to time. But just to go over the initial treatment regimens and how those have changed over time, you can see that when we started initially with the scale up, basically the emphasis was on using the cheapest drugs that would work, and the combination tended to be zidovudine with stavudine and 3-TC, and then either efavirenz or nevirapine. And because of the fear of putting women on efavirenz, basically women went on nevirapine in most countries, men onto efavirenz. There were some exceptions. For instance, Botswana started early on with efavirenz for both populations. These drugs were initially available as separate drugs. More and more combined tablets became available, and combined tablets from India in particular, and places that broke patent to produce cheap generics became widely available. And so that's where we started in 2006. And for those of you who remember stavudine, it's not a super drug. So countries that started with stavudine, when they had a lot of people with very advanced HIV, often anemia was so bad in those people that stavudine became used rather than zidovudine in a number of populations, particularly women. So there were a lot of people out there on D4T regimens. In pregnancy, it was avoided because of the high risk of lactic acidosis, but it was used in a number of other settings. So as we got to 2010, it was recommended to phase out zidovudine. And it's not until 2013 that the guidelines actually said discontinue zidovudine. So you may still find patients coming who have immigrated and are on zidovudine containing regimens, or sorry, on stavudine containing regimens, because their country just doesn't have the money to switch yet. So recently there's a big push for using TDF 3-TC as the preferred NRTI backbone. And nevirapine has fallen somewhat out of favor, in part because, of course, as we start with higher and higher CD4 counts, there's the risk of hepatotoxicity due to nevirapine in patients with higher CD4 counts. The alternatives are still there, but there is really this a big push to basically uniform TDF 3-TC efavirenz, and if you find a patient on any other regimen besides the ones on this table, they either were thought to have failed treatment, have had a number of drug reactions you'll have a very hard time figuring out, and or could afford to buy separately. Often in places like Kenya, private patients will be put on PIs until they can't afford them anymore, and then go on to one of these regimens in a public health center. So good to know, things to keep in mind. Earlier on we did much more complicated things with HIV-TB co-infection due to rifampin interactions. Rifamycin's generally not available, so basically the move has been towards just using efavirenz with rifampin. One comment just on HIV hepatitis co-infection, keep in mind that we don't know that in most patients because they've not had the hepatitis B screening. So people are starting and stopping regimens with hepatitis without any knowledge of that. So I'll mention just now sort of what's available in terms of prognosis following immigrations. I hope you've got a sort of a feel for what patients would have experienced before coming here. The foreign-born HIV patients are not tracked systematically by the CDC. There's usually not a breakdown. by that. There are people who are working on ways to identify and track foreign-born because it may be that the care cascade is different for that group than for some others. I've put together some of the more interesting recent data. There's a paper by Kong et al. That was reviewed TB patients in California and found that foreign-born TB patients were more likely to have new HIV diagnosis and have greater immunosuppression with very low CD4 counts, and that probably their TB could have been prevented by earlier HIV screening and potentially isoniazid. In a large cohort study led by Tim Sterling at Vanderbilt, TB was also very common. HIV-positive migrants had higher rates of AIDS-defining events than non-migrants, again, often due to more advanced immunosuppression, and TB was the most common AIDS-defining event. And then in New York State, they looked at their HIV diagnoses and found that the percentage of HIV cases in foreign-born, new cases, was increasing over time, and I think we're all going to start finding this. And that compared with the non-foreign-born, they were more likely to be diagnosed with AIDS, have a lower CD4 count, so a common theme. And they're, of course, often less likely to have insurance, and many of them need interpretation services. So I think there's increasing recognition that foreign-born are a discrete population that may need specific programs because of high levels of stigma and poor access to care, even here in the States.